Hi, welcome back to our GI series on student nurses success. This particular video is just going to focus on the pancreas and the gallbladder. Remember, our other videos in the GI series will cover general GI disorders, nutrition, the liver, and acute and chronic intestinal disorders. Let's go ahead and get started. And remember, you can find the link to the maps in the comments section. First, begin with the pancreas. Now, remember, the role of the pancreas is in both digestion and blood sugar control. We know that the pancreas makes insulin, and we know that it makes digestive enzymes, amylase and lipase. Now, of course, it does many more things than that, but those are just what we're kind of focusing on. And here I have a little picture of the pancreas over here. And one of the things that you're going to notice when we talk about the pancreas and the gallbladder together, it's because you can see the gallbladder in green really kind of connects to the pancreas right in that area. And so they all come together in what's known as the common bile duct. So when you start to have pancreatic disorders, sometimes you start to see gallbladder involvement. And so all of these kind of go together because of the proximity. So, pancreatitis, by definition, is inflammation of the pancreas. And the common causes of pancreatitis can be gallstone obstruction, because remember, if you look here, if we get a gallstone that gets stopped up right here, it can actually start to back up and cause pancreatic issues. We also know that high triglycerides can block the pancreatic duct because the liver is actually up in this area as well. And so liver issues can also cause pancreas issues. Alcohol abuse, genetics, infection, and trauma all relate to pancreatic disorders. Now, the pathophysiology behind pancreatitis is really the blockage of that pancreatic duct leads to increased pressure, and it causes those pancreatic digestive enzymes, amylase and lipase, we'll put that right there, to actually kind of leach out of the duct and start to digest the pancreas itself. So in this picture, you can see this duct should drain this amylase and lipase, but if it starts to back up, that amylase and lipase actually starts to leak into the pancreas. And amylase and lipase are digestive enzymes, so it actually starts to digest the actual pancreas. So it's almost like an auto digestion, and that causes a lot of pain. So, as it starts to digest and cause pain, it actually causes inflammation of the pancreas, scarring of the pancreas, and the pain. Over time, chronic and repeated pancreatitis attacks will lead to hardening of the pancreas, causing it to no longer function. And so in these particular cases, it actually will lead to no insulin production, and it will also lead to lack of amylase and lipase production. Now, we divide pancreatitis into two, acute pancreatitis and chronic pancreatitis. Acute pancreatitis would just be a pancreatitis attack, okay? So it's kind of like, a single attack, although you can have multiple ones of these attacks over time. In an acute pancreatitis attack, what patients experience is severe epigastric or left upper quadrant pain because that's where that pancreas is located. So we see that left upper quadrant pain, and sometimes it can radiate to the back. We also may experience nausea, abdominal distension, and even tachycardia, fever, hypotension, and jaundice. So, this tachycardia, fever, and hypotension can actually be just from this event, can be extremely serious, extremely painful, and cause a lot of issues systemically. The jaundice goes on, develops over time because what can happen is we get a backup into the liver. And so that actually can cause lack of draining of bile and can increase our bilirubin levels. Now, treatment for acute pancreatitis includes MPO. So, one of the problems is the pain from pancreatitis is from amylase and lipase that are leaking out into the pancreas and causing this autodigestion. Well, what stimulates amylase and lipase to be produced is food. So, our best bet is to just make the patient NPO to decrease the stimulation of the pancreas and the digestive enzymes to stop this autodigestion. However, if we make the patient NPO, we're going to actually need to increase some IV fluids. And so they're probably going to need to be in the hospital during that time because we have to have some type of fluids going in for them. We also focus on pain control and abstinence from alcohol because we know that alcohol actually seems to exacerbate and stimulate this process. Now, chronic pancreatitis is really when someone has had multiple acute pancreatitis attacks and over time has just made their pancreas damaged. So the problem is each time you have a pancreatitis attack, you have a little bit more of your pancreas that's hardened and damaged and scarred. And so after a certain point, when the pancreas is so damaged from that, we call that a chronic pancreatitis. Patients with chronic pancreatitis still may have the pain and the nausea and vomiting from the attacks, but because their pancreas is no longer really making amylase and lipase that is able to get into the stomach to digest their food, we see a lot of issues with malnutrition and malabsorption, weight loss, gas or flatulence, even constipation and malabsorption from the disease process. We also, because the pancreas becomes hardened and doesn't make amylase and lipase, it also doesn't make insulin. And so over time, they actually may develop diabetes. For patients with chronic pancreatitis, they're still having some of these acute pancreatitis attacks. So they still have the pain issues with that, but really their issues are more long-standing with nutrition because they're not making amylase and lipase. So because they're not making enough amylase and lipase, we actually do pancreatic enzyme replacement every time they eat. They take some enzymes and actually directly put them into their stomach so that they can digest their food. Additionally, they may need insulin as well. And of course, again, abstaining from alcohol because it's known that alcohol just really exacerbates and worsens this process. The labs that we see in pancreatitis, we will actually see a rise in serum amylase and lipase levels. And that's how we know that beyond their manifestations of pain, that they're having pancreatitis. So what happens with this amylase and lipase, because it's not gaining access into the intestines and the stomach in order to digest food, and it's kind of leaching into the pancreas, it then starts to absorb into the bloodstream. And so we do see a rise in the serum blood levels of amylase and lipase, and that's pretty indicative of acute pancreatitis. Pancreatic cancer, we're not going to talk a lot about it, but pancreatic cancer is both difficult to diagnose and treat. And because it's difficult to diagnose, it's often advanced when we do identify it. And as we know with all cancers, the more advanced they are at diagnosis, the more difficult the prognosis is and more difficult treatment is. So we do see a poor prognosis with pancreatic cancer because it is often pretty advanced when it is diagnosed. Risk factors of pancreatic cancer include smoking and obesity, but certainly those aren't the only ones, but we do see that playing a role. Manifestations, how do you know you have pancreatic cancer? Again, it's usually fairly advanced, but what we see is jaundice start to develop in individuals. And that's because as the pancreas becomes kind of invaded with those cancerous cells, we start to see a blockage of the common bile duct. And so what we see is the bile backing up into the liver and causing jaundice. Patients also start to have malabsorption issues, weight loss, pain, and nausea because what happens, they're not making enough pancreatic enzymes. So we start to see the nutritional effects of that. All right, and let's finish off here with cholecystitis, which we know is gallbladder disease. So that's the official term for it. Again, we see a picture here is our liver. We see our gallbladder right here. Again, this is our pancreas. And you see where all of this kind of comes together in this area. And so we start to see a lot of these symptoms overlapping between liver disease, gallbladder, and pancreas issues. So cholecystitis is the development of gallstones, and these gallstones can obstruct the cystic duct. And this right here is your cystic duct, causing pain and a backup of bile into the liver. And in fact, it actually causes post-hepatic jaundice. And if you're not sure what that means, go ahead and circle through our liver video, and we'll talk all about jaundice hepatic, hepatic, and post-hepatic jaundice. So if you're not sure what that is, watch our liver video to kind of learn a little bit more about it. Over here, we see a little picture of these gallstones. Gallstones are really just cholesterol that is starting to kind of collect and develop into these stones. And when you eat a fatty meal, this gallbladder here contracts and starts to actually squirt bile out into the intestine. However, if there's stones, it can squirt these stones out, and these stones get lodged here and cause pain. In addition, what we see is a backup, and actually, this will back up this cystic duct into the liver. And so we actually see a backup of bile into the liver, causing jaundice. And that's pretty much the process there. As far as causes of cholecystitis or gallbladder disease, we know that rapid weight loss actually can kind of start some gallbladder disease. In individuals who have rapid weight loss, they start to burn a lot of fat, and that actually can increase the development of gallstones. Um, we know that obesity increases the risk of gallstones, family history, hyperlipidemia, and we see more females than males with gallstone development. What we see is cholesterol and calcium start to form these stones. And we've got these stones right here, and these stones get stuck in the cystic or common bile duct, either one. And when they get stuck, they cause inflammation, ischemia, and that ischemia can cause pain and also a backup of bile into the liver that causes this post-hepatic jaundice. Eventually, pressure from the stone on the wall can lead to thickening of that wall and eventually necrosis on severe pain, and that gallbladder needs to be removed. Patients generally present with colicky right upper quadrant pain, and that right upper quadrant pain radiates to the back. And that pain is often precipitated by a meal. And that's because at the meal, they will squirt out extra bile in order to digest and break down the fats. We also see the development of jaundice. We've talked about that a few times already, why that occurs. We see from the malabsorption and not using enough bile to break down their food, we see bloating and even clay-colored stool. Treatment of gallstone disease is you can use lithotripsy to kind of break up sound waves to break up those stones into smaller ones, or usually what we just do is removal of the gallbladder and surgery. Now, individuals can live absolutely fine without a gallbladder. You will still make bile, so the bile will still be made. It just won't be stored. So this will be removed, but bile will still drip down into the intestine, um, and that will work out fine for individuals unless they eat a real large fatty meal, and then they won't get that extra squirting or dose of bile that's been stored in the gallbladder. There you go. Make sure that you tune in for our liver video and also our video on the rest of the small intestine, stomach, and large intestine GI disorders.